Good evening, everyone. District Ayurveda Hospital, Varkala is inviting you to a warm we welcome.
Good evening, everyone.
Good evening, everyone. District Ayurveda Hospital, Varkala is inviting you to a World Auto-Inflammatory Arthritis Day special webinar on Zoom virtual platform. Today, we have a resource person, Dr. Shibu Varghese, Professor, Superintendent at Nangeli Ayurveda Medical College. He will lead the session on the topic investigation in inflammatory arthritis. So, first of all, I invite Dr. Shibu. We welcome you, sir. And once again, I invite our beloved participants.
Hello, sir. Sir, please unmute, sir.
Yeah. Good evening. Good evening.
Good evening, sir.
Yeah. Am I audible properly?
Audible, sir. Clear, sir.
Okay. Just now I got login actually. I didn't hear what you are telling, what you're speaking.
Okay.
Good evening, sir.
ഇതിനകത്ത് വന്നിട്ടുള്ളത്
ഇപ്പോൾ സ്ക്രീൻ വിസിബിൾ ആണ്, സർ. സ്ക്രീൻ ഷെയറിംഗ് ആണ്, വിസിബിൾ ആണ്. Sir, please unmute, sir. Please unmute your voice.
അതിൽ പവർ പോയിന്റ് ഓപ്പൺ ആയി വന്നിട്ടില്ലല്ലോ.
ഇല്ല, സൂം ആണ് കാണുന്നത്. സൂം മീറ്റിംഗ്. ഓക്കെ സാർ, ഇപ്പൊ പവർ പോയിന്റ് കാണാം.
ഏതാ?
ഇപ്പൊ പവർ പോയിന്റ് കാണാം സാറേ.
അല്ലേ, അത് ഫുൾ സ്ക്രീൻ
സ്ലൈഡ്
ആയിട്ടുണ്ടാവും. പവർ പോയിന്റ് ഫുൾ സ്ക്രീൻ ആയോ?
ഇപ്പൊ ഫുൾ സ്ക്രീൻ ആയി.
ഫുൾ സ്ക്രീൻ ആയല്ലേ. തുടങ്ങുവാണോ അത് ഇൻട്രൊഡക്ഷൻ എന്തെങ്കിലും ഉണ്ടോ? എങ്ങനെയാണ്?
ഡോക്ടർ ഐശ്വര്യ? ഇൻട്രൊഡക്ഷൻ കഴിഞ്ഞു സാറേ, ഇനി സ്റ്റാർട്ട് ചെയ്യാം സാർ.
ആണോ? ഓക്കെ ഓക്കെ. So very good evening to all. So it's a privilege to take a class to Varkala Government Ayurveda Dispensary, because that Varkala Ayurveda Dispensary is very dear to me, because I was supposed to join there as a specialist medical officer there, but it didn't happen. So let me directly go into the class. So today's topic is biochemical investigations in inflammatory arthritis. The topic is biochemical investigations in inflammatory arthritis. As you know, we Ayurvedic people deal much with the inflammatory arthritis. So in the inflammatory arthritis, the diagnosis is a vital part in the management of inflammatory arthritis. And most of the main problem what we deal is that the symptoms overlap each other. So usually the investigations help us in diagnosing different clinical conditions. If you take the autoimmune disease, whether it is a systemic lupus erythematosus, systemic lupus, Sjogren's syndrome, etc., the symptoms overlap. So many times the biochemical investigation helps in diagnosing that particular disease. So Ayurveda says that Rogamado parikshade tadanandaram aushadam. That means before treating a patient, the disease has to be properly diagnosed. So in the present day clinical practice, lot of investigational tools are available. There's a quantum jump in the investigational backup, and the present day clinical practice without investigational backup is never imaginable. Also, the patients what we deal, they also demand a proper diagnosis before starting a treatment. They want the diagnosis not only through the Darsana Swasana Prashna, but they want a concrete diagnosis with the help of either a radiological investigation, biochemical investigation, whatever investigation tools are available. Patient also demands that investigations. So today my attempt is to just to give a light into the biochemical investigations in inflammatory arthritis. So first is inflammatory markers. As you know, if there is an inflammation, if there is any inflammation develops in our body, there will be inflammatory markers can be detected in the blood. So usually whenever there is an inflammation, extra proteins will be released from the body, and that extra proteins can be detected with the help of the inflammatories, either the ESR, plasma viscosity, and C-reactive protein. So I mean that the C-reactive protein and ESR are the most commonly used inflammatory markers. Suppose if an inflammatory marker is raised in the body, it does not indicate a particular disease, but it indicates that there is something wrong happening in the body, something not well in the body, or that is called a sickness index. Suppose if the ESR is above 100, definitely means that there is something wrong happening in the body, and it alerts the clinicians to see why it has gone wrong. So it does not indicate a particular disease, but it gives us a sickness index. That means something wrong happening in our body. First, let me come into the ESR. So ESR is one of the oldest tests, but it has got still good applicability, even though this applicability has been taken over to some extent by C-reactive protein, but still we depend upon ESR for diagnosis of many inflammatory diseases, for example, rheumatoid arthritis. So normally, the normal ESR is 0 to 15 in males and 0 to 20 in females. If there is any inflammation in the body, the ESR will be raised. ESR has got some physiological influence also. If the patient is in the old age, if the patient is obese, if the patient is lactating, if the patient is pregnant, in such conditions also the ESR will be raised. But that will be raised up to only at a certain level, up to 20, 30, or 40 maximum. But if it is raised beyond a particular limit, it indicates that there is something wrong happening in our body. So ESR has got some diagnostic influence in inflammatory arthritis. In rheumatoid arthritis, the American College of Rheumatology has considered ESR as one of the diagnostic criteria for diagnosing rheumatoid arthritis. Secondly, in temporal arteritis and in polymyalgia rheumatica. In these two conditions also, ESR is found to have some diagnostic value. Usually in polymyalgia rheumatica or in temporal arteritis, the ESR will be usually raised and the ESR will be in par with that of the disease activity. If the disease activity is very high in temporal arteritis and polymyalgia rheumatica, the ESR will be above 100. If the disease activity is not very high, it may come to 50 or so. So to understand about the disease activity also, ESR is having some value, not only for the diagnosis, but for the understanding the disease activity also, ESR is found to have some diagnostic value. Suppose if a patient has come to you with a raised ESR, if an asymptomatic patient comes to you without with a raised ESR above 80 or 100, in such condition, what you have to do? What will be your next diagnosis, or how will you go ahead with the next diagnostic plan? So normally, if the ESR is raised, first what you have to go for a hemogram or a CBC has to be done. That should be the first step if you just see a raised ESR. Second, you have to go for a chest X-ray, because sometimes a raised ESR without any symptoms, it could be a chest pathology or something. Second, you have to go for a liver function test. In liver pathologies also, ESR will be very much raised. And next in renal function test. If there is a renal pathology, if there is a renal failure, there can be a raised inflammatory marker. So these are the initial tests to be done if you find an inflammatory marker without any obvious clinical presentation. Then urine routine also has to be done. That's also part of the investigation. Next comes in inflammatory arthritis. In inflammatory arthritis, ESR will be raised along with the CRP. So what is the difference between ESR and C-reactive protein in inflammatory arthritis? ESR is an indirect sign of inflammation and C-reactive protein is a direct sign of inflammation. Suppose if a patient has got a sudden explosive onset of rheumatoid arthritis, or if there is a palindromic rheumatism, so C-reactive protein will be detected in the blood within 2 hours of the acute inflammation. But ESR takes some time for that to develop. At the same time, by the medicine, if the inflammatory arthritis, the palindromic rheumatism get subsided within a stipulated time, within 18 hours, the C-reactive protein will come back to normal. But ESR takes some time for that to come back to normal. So that is a difference between ESR and C-reactive protein. One is C-reactive protein is a direct sign of inflammation, because whenever there is an inflammation, infection, or an autoimmune activity in our body, what will happen? Extra proteins are released from the liver. That is called a C-reactive protein, and that is a direct sign of inflammation. But ESR is an indirect sign of inflammation, and it takes some time for that to get raised. But C-reactive protein, before the symptoms like fever, etc., will develop, within 2 hours itself, C-reactive protein can be detected in the blood, and it peaks within 48 hours of the acute inflammation. So that is the difference between C-reactive protein as well as the ESR. So ESR, now also, even though it's an oldest test in temporal arteritis, rheumatoid arthritis, polymyalgia rheumatica, and in multiple myeloma, in these 4 clinical conditions, ESR is found to have a diagnostic value also. Not only for the diagnostic purpose, but to assess the disease activity in inflammatory arthritis, ESR is very much helpful. Suppose if the rheumatoid arthritis is in a very active phase, ESR may go about to 80 or 100, etc. But if the disease is in a dormant phase, if it is not very active, ESR may come back to normal, or it may be marginally raised only. So to understand about the disease activity and to help in the to assist in diagnosis of other inflammatory conditions also, ESR is found to be very much helpful. That's about the inflammatory markers. Even though now C-reactive protein is slightly expensive test, nowadays C-reactive protein has taken over the advantage of ESR, or the diagnostic value of inflammatory arthritis rather than ESR. Because quick response can be expected in C-reactive protein. Because if you give a medicine, whether the medicines has acted or not, within few hours itself, we can come to know with the help of the C-reactive protein. But ESR, it takes few days to weeks or sometimes months to get the response. That is the difference between C-reactive protein as well as the ESR. Next is the rheumatoid arthritis. As you know, suppose if a patient comes to you with the pain in the multiple joints, with the evening rise of temperature, with the loss of appetite, fatigue, etc., you may doubt about whether the patient is having a rheumatoid arthritis or not, because clinically these arthritis may overlap each other in the symptoms. So we need to know whether the patient is having a rheumatoid arthritis or a reactive arthritis or any other type of arthritis. In such condition, along with the physical examination, this hematological test will help us to understand, to help us to diagnose that particular clinical condition. If you suspect a rheumatoid arthritis, the first investigation what you have to do is that a CBC, complete blood count, has to be done. In that, usually, if the patient is having a rheumatoid arthritis, the patient may be having a reduced hemoglobin level. Usually, patient will be having a reduced hemoglobin level. The reason is that if the patient is having a chronic arthritis or a chronic inflammatory arthritis, the total iron binding capacity will be less, and the patient will not be able to absorb iron from the gut. So as a result, what will happen? There will be anemia will be there. So usually patient with rheumatoid arthritis may not be there in the very initial phase, but after some time, definitely patient will be having a anemia. Second is the patient will be definitely having a raised ESR will be there. Usually if the patient is having, if there is an active inflammatory rheumatoid arthritis, patient will be having a raised ESR, usually above 50 will be there. If it is very active, it may go above 80 or 100, etc. So ESR will be definitely raised. Then C-reactive protein. C-reactive protein will be raised if the disease is in an active phase. If the disease, the inflammatory phase is very active, the C-reactive protein also will be raised. Usually, it will be above 40. The normal level of C-reactive protein is 10. But if the disease activity is very active, definitely the level of C-reactive protein will be above 40. It can go up to 200 if there is a severe rheumatoid arthritis. Then there will be pancytopenia will be there. That means the WBC, RBC, and platelets will be reduced in case of rheumatoid arthritis. That's in advanced stage of rheumatoid, not in the very early stages of rheumatoid arthritis. But usually the RBC, WBC, as well as platelet count will be reduced in case of rheumatoid arthritis. Then two specific tests. One is the rheumatoid factor as well as anti-cyclinated citrullinate peptide, both will be positive. And in the urine, usually the rheumatoid arthritis affects the kidney, and as a result, there will be proteinuria will be there. So these are the general biochemical investigations and its results which is seen in case of rheumatoid arthritis. So I repeat, normally anemia will be there, raised ESR will be there, raised C-reactive protein will be there, then pancytopenia will be there. In the advanced stage of the disease, RA factor will be positive, anti-CCP will be positive, and then the proteinuria can be detected in the urine. Let us come to the rheumatoid factor. Suppose a patient has come to you, he is above 65. He does not have any joint pain or any other symptoms. But on a routine investigation, if his RA factor is positive, do you consider him as a case of rheumatoid arthritis? No, you can't, because usually above 65 years, 20% of the patient will be having a RA factor positive. That doesn't mean that he is a patient of rheumatoid arthritis. So next is temporarily after vaccination and blood transfusion. Suppose if you had gone for a blood transfusion, or if you had vaccinated for COVID or any other vaccination, temporarily you may be having a RA factor positive. That doesn't mean that you are a patient of rheumatoid arthritis. And next in other autoimmune disease like collagen vascular disease like systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, and dermatomyositis. In those clinical conditions also, RA factor will be positive. So RA factor is not only confined to rheumatoid arthritis, but in collagen vascular diseases like SLE, systemic sclerosis, Sjogren's syndrome, and dermatomyositis. In those clinical conditions also, RA factor will be positive. And in other infective conditions like tuberculosis, leprosy, malaria, filariasis, endocarditis, hepatitis B, etc. In those infective conditions also, patient may be having a RA factor positive. That doesn't mean that patient is having a rheumatoid arthritis. In certain liver disease like autoimmune liver disease like primary biliary cirrhosis, sarcoidosis, fibrous alveolitis, in those conditions also, the RA factor can be positive. So then what is the importance of this rheumatoid arthritis? So it can be positive in many other clinical conditions. Also, sometimes the patient may be having a severe joint pain. Evening rise of temperature will be there, swelling will be there, but the RA factor will be negative. In such conditions, sometimes we may consider it as a case of rheumatoid arthritis, or we may put in a category of seronegative rheumatoid arthritis. So RA factor positive does not conclude a rheumatoid arthritis, as well as RA factor negative does not rule out a rheumatoid arthritis. Then what is the importance of this rheumatoid factor? So it helps in assisting us for the diagnosis. If the clinical conditions like joint pain, even rise of temperatures, symmetrical arthritis, etc. is there, along with that, if RA factor is positive, then we can consider it as a case of rheumatoid arthritis. But mainly it is used for a prognostic purpose. Suppose at the time of diagnosis, if the titer of RA factor is very high, it indicates that patient is going to have a very worse erosive rheumatoid arthritis. So RA factor helps in the diagnosis and helps in assisting the diagnosis. At the same time, it helps for the prognosis of the disease. That is the importance of rheumatoid factor. But rheumatoid factor can be many times, as I said, it can be negative in rheumatoid arthritis. It can be positive in many other clinical conditions. So much more specific test or a gold standard test in rheumatoid arthritis called as anti-CCP. That means anti-cyclic citrulinated peptide test. That is about 75% of the patient with the RA factor will be having a anti-CCP positive. So that is more specific test for rheumatoid arthritis. Sometimes RA factor may be negative, but anti-CCP will be positive. So anti-CCP is considered as a gold standard test for diagnosing rheumatoid arthritis. Even after the clinical examination, even after the history, even after the RA factor test, if you still have a doubt whether this is a rheumatoid arthritis or not, in such condition, you can go for this test, that is ACCP or anti-cyclic citrulinated peptide test. This is called as the gold standard of diagnosis of rheumatoid arthritis. And the normal value is 0 to 20 units per millimeter. That is a normal value of anti-CCP. Then let us go for the interpretation of this ACCP. So what does this result mean? A positive CCP antibodies and positive rheumatoid factor, usually if both are positive, the patient is likely to have a rheumatoid arthritis. In the clinic, if suppose if a patient comes with the joint pain and his RA factor is positive, and if his CCP is positive, the patient is likely to have a rheumatoid arthritis. You can clinch the diagnosis. Almost you can make sure that the diagnosis is rheumatoid arthritis. Next is the CCP will be positive and negative rheumatoid factor. It can happen in the early stage of the rheumatoid arthritis. In early stage, the RA factor may not be positive, but still in milder rheumatoid arthritis. But the CCP will be positive. So the patient is likely to have a rheumatoid arthritis, or he is in the early stage of the rheumatoid arthritis, and over a period of time, the patient is definitely going to develop a rheumatoid arthritis. The negative CCP and a negative rheumatoid factor, the patient has got a very lower chance of developing rheumatoid arthritis. I repeat, it is lower chance. Doesn't rule out rheumatoid arthritis completely. Sometimes I've seen many patients who was having a rheumatoid arthritis with the negative CCP and negative rheumatoid factors. But in general rule, Usually positive CCP and positive rheumatoid factor, definitely the patient will be having a rheumatoid arthritis. Positive CCP and negative rheumatoid factor, the patient may be in the early stage of the rheumatoid arthritis. In the due course of time, patient is likely to develop a rheumatoid arthritis. If both are negative, the chances of rheumatoid arthritis is very less, but there are exceptions are also there. That's about the diagnosis of rheumatoid arthritis. So let us repeat once again. In rheumatoid arthritis, what will happen? Anemia will be there, raised ESR will be there, raised C-reactive protein will be there. In later stage or advanced stages, the pancytopenia, that means RBC, WBC, and platelets will be less. RA factor will be positive, anti-CCP will be positive, and there may be proteinuria in the urine. So these are the investigations to be done in rheumatoid arthritis. With the help of these investigations, with the clinical findings and history, we can almost diagnose a case of rheumatoid arthritis. Next is serum uric acid test. That can cause an inflammatory arthritis called a gouty arthritis. So nowadays, in the present clinical scenario, many patients come to our clinic with the gouty arthritis. The different variants of gouty reaction may be present. Sometimes, suppose if a patient comes to you with says that he is having a pain in the neck, pain in the upper back and lower back, and when we palpate the spine, there may be tenderness all along the spine. Usually, the tenderness is because of the endosopathy. So now the present clinical scenario, the endosopathy is mainly because of a gouty reaction. So not only in the toe, even though in the typical gouty arthritis occurs in the toe, but now it is not only in the toe, but it can be there in the wrist joint, it can be there in the elbow, it can be there in the shoulder, it can be in the muscle region, it can be in the spine, anywhere. It can be in the knee, anywhere there can be a gouty reaction. But usually, when the textbook says that the commonest site of gouty reaction is at the root of the toe. That is the commonest site, but it's not a rule that there has to be at that particular site. Sometimes there may be a shoulder pain, there can be a muscle inflammation. Many times I have seen nowadays the presentation is sometimes the patient comes and says that he's having a very severe pain in the hand region, at the muscular region, and when you palpate, when you try to touch, it will be very hard and very warm in nature. That is because of the gouty reaction. Second, how do we diagnose a gouty arthritis? Usually, when a patient comes to you with the red swollen area at the root of the toe, you may doubt about a gouty reaction and send for a serum uric acid test. The uric acid result comes very normal. Do you rule out gouty arthritis? No. When during the acute phase of gouty reaction, all of the uric acid will be deposited at the site of the inflammation, and from the systemic circulation, you may not be able to detect it. So, after a few days, once the acute inflammation settles, then if you check the blood test, you may get a high uric acid test. So, only if you test the uric acid, and if the uric acid levels are in the normal limits, should not rule out a gouty arthritis, because during the acute phase of the inflammation, what will happen? The whole of the uric acid will be settled or crystallized at the site of the inflammatory arthritic site, and you may not get it detected in the systemic circulation. So don't rule out a uric acid gouty arthritis only because of the uric acid levels are normal. Uric acid levels can be higher after a few days, or once the acute inflammation subsides, it may revert back to the systemic circulation. Second thing, some patients can develop a gout even though they may be having the normal level of uric acid is males it is 4 to 7.2 and females it is 2.7 to 6.5. Certain patients may be having a regularly low levels of uric acid, but still they can have a gouty reaction. So it doesn't mean that uric acid level should be higher to have a gouty arthritis. Some patients, if they are having a very low uric acid levels, continuously also can develop a gouty reaction. So uric acid levels are not a very dependable marker for diagnosing this gouty arthritis. For that, a synovial fluid aspiration, cytology is very important. When you aspirate the synovial fluid, and if you check it in the microscope, you can get a urate crystals can be detected. A pin-shaped, the needle-shaped crystals can be detected, and the diagnosis group. That's more reliable test for diagnosing gouty arthritis rather than a serum uric acid test. But if a patient is having a recurrent gouty reaction with the raised ESR, means the diagnosis is very confirmed. It is a case of a gouty reaction. So gouty arthritis has to be a clinical diagnosis, and only to reconfirm your clinical diagnosis, you can depend upon uric acid levels. If it is low, also should not rule out a gouty arthritis, because it can be low during the acute inflammation, where it will be settled in the particular site of arthritis. And also some patients can have a gouty arthritis without a raised uric acid levels. So that's about the uric acid test. So normally, the uric acid is a byproduct of purine protein, and mainly, especially in alcohol, especially in red meat, especially in sugar, and especially if you take organ meat, etc. In such conditions, there can be a raised ESR. If you are on diuretics, if you are on thiazide type of diuretics, in such conditions also the uric acid levels will be raised. So advise the patient to reduce the red meat intake or a purine protein intake, like reducing lentils, red meat, alcohol, and advise them to drink plenty of water, 3 to 4 liters of water in a spread out manner will definitely help to reduce the uric acid level, and advise them to have a proper exercise. So in the present clinical practice, if there is an endosopathy, like if there is a supraspinatus tendinitis, if there is a tennis elbow, if there is a plantar fasciitis, always you should check whether the patient is having a high uric acid or not. The uric acid level has to be checked. Even if it is normal, also should not rule out the possibility of a gouty arthritis, because it can happen in a very low uric acid levels also. That's about the serum uric acid test. Next is about anti-nuclear antibody test. So, normally there is a defense system is present in our body. Usually that defense system works whenever some bacteria, virus or something invades our body. But sometimes what will happen, our own immune system may confuse our own body parts as a foreign material and starts attacking. So that condition is called as autoimmune disease. If you are having an autoimmune disease, if you suspect a autoimmune disease, what will happen? What has to be done? A test called anti-nuclear antibody test has to be done. So as I initially said, the immune system normally fights off dangerous infections and bacteria to keep the body healthy. But an autoimmune disease occurs when the immune system attacks the body because it confuses it for something foreign. So there are many autoimmune diseases. There are many autoimmune diseases, including systemic lupus erythematosus, Sjogren's syndrome, etc. This ANA test or anti-nuclear antibody test looks for anti-nuclear antibodies in the blood. If the test finds anti-nuclear antibodies in blood, it may mean that you have an autoimmune disorder. So an autoimmune disorder causes your immune system to attack your own cells, tissues, and organs by mistakes. So next is, what are the indications of this anti-nuclear antibody? So an anti-nuclear antibody test is used to help diagnose autoimmune disease, including systemic lupus erythematosus, rheumatoid arthritis, scleroderma, Sjogren's syndrome, etc. Suppose a patient has come to you with a severe joint pain, fever, red rashes, dry eyes, etc. So you are not very sure what type of autoimmune disease it is, because ANA test only detects that the patient is having a autoimmune disease or a presence of an autoimmune disease has been confirmed with the help of an anti-nuclear antibody test. But one problem with anti-nuclear antibody test is that it may be positive. 1/3 of the patient above 60 will be having a ANA test positive. That does not mean that patient is having a autoimmune disorder. If a clinical symptom with a positive anti-nuclear antibody, then only we have to doubt about the possibility of an autoimmune disease. Because a positive test result doesn't necessarily mean you have a disease. Some healthy individuals have anti-nuclear antibodies in their blood. In addition, certain medicines can affect the results. So, as I said, if an ANA test is positive and you are not sure about what disease it is, in such condition, you have to go for one more test called the ANA profile or a ENA profile. That means extractable nuclear antibodies. This is ANA profile. So, normally there are many tests in the ANA profile. First is anti-DS DNA. That is anti-double stranded DNA. That is first test in the ANA profile. This anti-DS DNA is very suggestive of a systemic lupus erythematosus. If ANA test is positive, along with that, if anti-DS DNA is positive, then the possibility of the diagnosis of SLE is very confirmed. Second is anti-Smith antibody. That is also positive, seen in 30% of the patients with the systemic lupus erythematosus. So I repeat, I am coming to that later on. So if ANA test is positive, along with that anti-DS DNA and anti-Smith is positive, then the diagnosis of systemic lupus erythematosus is almost confirmed. Suppose if ANA test is positive and anti-RNP or ribonucleoprotein test is positive, it is diagnosis of a mixed connective tissue disorder. But one problem is that it may be positive in SLE and scleroderma also. But 95% of the patients with the mixed connective tissue disorder will have a positive anti-ribonuclear protein. So ANA is positive with the anti-RNP is positive. The possibility of diagnosis of mixed connective tissue disorder is very high. That means about 95 to 100% is the thing. Suppose if the patient is having a dry eyes, okay, coming to that later. If the patient is having ANA positive with the anti-SSA, anti-Sjogren syndrome A, and anti-Sjogren syndrome B is positive, then the possibility of diagnosis of Sjogren syndrome is very high. So if ANA is positive, anti-SSA and ASSB is positive, then the diagnosis is Sjogren syndrome. Next, if the ANA is positive and anti-scleroderma 70 is positive, then the diagnosis will be scleroderma. Then if ANA is positive and anti-Jo1 is positive, then the diagnosis of polymyositis will be the diagnosis. This is called as ANA profile. So if you diagnose a patient with if a suspected collagen vascular disease, and if ANA test is positive, next what you have to do is you have to send for an ANA profile, or some places it is called as ENA profile, that is extractable nuclear antigen profile. In this, these tests will be there. So what type of autoimmune disease can be detected with the help of this ANA or ENA profile? Now let's come to the systemic lupus erythematosus. So systemic lupus erythematosus, it is a systemic autoimmune disease that occurs when immune system attacks your own tissues. Inflammation caused by lupus can affect mainly different body systems, including joints, skin, kidney, blood cells, brain, heart, lungs, etc. And the problem with the SLE is that the symptom can vary and change over time. That is one of the problems. The diagnosis will be at a difficulty because the symptoms can vary and change over time. The common symptoms include the patient may be having a severe fatigue will be there, joint pain will be there, joint swelling will be there, headache will be there, a rash on the face that is called as butterfly rash, or it is called as malar rash because it occurs on the cheek. hair loss. The patient with the systemic lupus erythematosus will be having a severe hair loss. Many a times, a patient, we may think that the patient is having a rheumatoid arthritis, but by seeing the profuse hair loss, we may think otherwise, and when we do the ANA test, it may be positive. So hair loss is another symptom. Anemia will be there. Blood clotting problem. The blood may not clot. Then the fingers may turn white or blue when exposed to cold, which is called as Raynaud's phenomena. When these symptoms are seen, we may doubt about the possibility of a systemic lupus erythematosus. So if you see these symptoms, that means undue fatigue, joint pain, joint swelling, headache, then malar rash, hair loss, anemia, blood clotting problems, etc., then we have to go for a test called the anti-nuclear antibody test. If anti-nuclear antibody test is positive, then we need to reconfirm whether it is a systemic lupus erythematosus or not. For that, we need to go for another test. One is the anti-DS DNA. So this anti-DS DNA is very characteristic of active systemic lupus erythematosus. If the SL is active, definitely anti-DS DNA will be positive. Next is anti-Smith antibody. This also will be positively seen in case of 30% of the patient with the lupus. But very specific antibody. If the anti-Smith antibody is present, then definitely it is a systemic lupus erythematosus. But if it is not seen, it does not rule out SLE. But if it is positive, definitely it is a case of systemic lupus erythematosus. Patient will be having severe anemia. Usually the HB levels will be below 10 if the patient is having an active systemic lupus erythematosus. They will be having a low white blood count, low platelet count. That means pancytopenia is generally a feature of SLE and even rheumatoid arthritis. And also patient will be having a very high amount of protein in the urine. Or usually in the urine, in the report, there will be cast will be found in the urine. Protein cast will be seen in the urine. So these are the diagnostic tests for systemic lupus erythematosus. To reconfirm the diagnosis systemic lupus erythematosus, ANA, anti-DS-DNA, anti-Smith antibody, then HB, and other CBC has to be done, and high protein in the urine. These are the characteristic feature of systemic lupus erythematosus. Nowadays, the diagnosis is very advanced. When the American College of Rheumatology suggests even a renal biopsy to reconfirm the diagnosis of systemic lupus erythematosus. And there can be sometimes carditis would be there, pleuritis would be there. These are the other systemic problems which can be associated with the systemic lupus erythematosus. And one thing I need to remind you about the practitioners of Ayurveda, because if a patient comes with the systemic lupus erythematosus, you may sometimes, patient may be on treatment from allopathic medicine, they may be on steroids. All of a sudden should not stop the steroids. Especially in systemic lupus erythematosus, I usually suggest the patient to have a low dose of steroids, sometimes 5 mg of prednisone, at least alternative days. Stopping the steroids completely can have a very bad systemic involvement of systemic lupus erythematosus. Even though if you are giving your medicine as an adjuvant, be on a low dose of steroids, because with the help of our medicines, the higher dose of steroids can be reduced, and it can be reduced to alternate it, but don't stop it completely, because that can damage the internal organs very fast, which is irreversible. So you have to taper the dose of the steroids very cautiously, but always keep a minimal dose of steroids in systemic lupus erythematosus. Otherwise, the disease may advance very fastly, which is irreversible. Always that has to be. I think that's what I learned from my clinical practice. There are a few other tests are also indicated to detect after diagnosing systemic lupus antibodies what type of systemic lupus it is. So ANA test we have done, anti-Smith which has been already. Sometimes histone antibodies may be positive. If there's a histone antibodies is positive in systemic lupus erythematosus, it is very indicated that patient has developed the systemic lupus erythematosus from a drug-induced. Certain drugs can induce systemic lupus erythematosus. So if it is a drug-induced or not, we can go for the histone antibodies. Then antiphospholipid antibodies, etc., can be done. Suppose if there is a rashes in the legs and we suspect the antiphospholipid syndromes, in such condition, antiphospholipid antibodies also can be seen. Usually in the clinical practice, in our general clinical practice, first 3 tests are sufficient: anti-nuclear antibody test, anti-Smith antibody, and anti-double stranded DNA test. These tests are sufficient to diagnose a systemic lupus erythematosus. Then next is mixed connective tissue disorder. In mixed connective tissue disorder, the ANA test will be positive and anti-ribonucleoprotein test, which is in the ENA profile, will be seen in 95 to 100% of patients with the mixed connective tissue disorder. Next is the Sjogren's syndrome. Sjogren's syndrome, as you know, it's an autoimmune disease, and the signs and symptoms also can vary from person to person and change in type and severity over time. For that, we need to be a very experienced clinician to diagnose a Sjogren's syndrome, because the clinical symptoms can vary from person to person. They may include non-specific symptoms like a chronic fatigue, fever, and may involve various parts of the body such as skin, joints, lungs, nerve, kidneys, etc. And sometimes digestive tract also. So you have to be very tricky, or you have to be very experienced to diagnose Sjogren's syndrome. But the common symptoms of Sjogren's syndrome are usually a decreased sense of taste and smell. Then dry cough may be there. Dry and gritty eyes. That dryness of the eyes, we call it a dry and gritty eyes will be there. Dry mouth with the difficulty in swallowing as well as in talking. Then dry skin and rashes will be there. Dry skin, the skin will be always dry and rashes will be there. Then fatigue will be there. Joint pain and swelling will be there. Muscle pain will be there. Numbness in the hands. Neuropathy is another classical picture of Sjogren's syndrome. Then sore tongue or sore throat. Always patient will be having the tongue will be sore and throat will be sore. Then swollen salivary glands. Usually the parotid glands will be swollen in case of Sjogren's syndrome. In active Sjogren's syndrome, always the parotid glands will be swollen. Vaginal dryness will be there. Stomach upset, irritable bowel syndrome, and recurrent bronchitis. These are the general symptoms which usually occurs with the Sjogren's syndrome. But usually the eyes and mouth will be dry. Dryness is one of the commonest symptoms which can be observed in Sjogren's syndrome. If you suspect a Sjogren's syndrome, what you have to do? You have to do the ANA test. After, if the ANA test is positive, then you have to go for the ENA profile or ANA profile, and in that anti-Sjogren's syndrome A will be positive in 75% of the patients with the Sjogren's syndrome, and anti-SSB also will be positive in 60% of the patients with the Sjogren's syndrome. So I repeat, if the clinical symptoms like dry cough, dry gritty eyes, dry mouth, dry skin and rashes, then dry vagina, sore throat, etc., along with your skin rashes and fatigueness, you have to doubt about the Sjogren's syndrome and go for this ANA profile and do anti-SSA antibody as well as anti-SSB. Usually in 75% of patients with the Sjogren's syndrome will have a anti-SSA positive. So this is about the diagnosis of Sjogren's syndrome. And let's go for a little elaboration about the Sjogren's syndrome. So as I said, ANA will be positive. Then anti-SSA, ASSA and SSB will be positive. And the patients with the Sjogren's syndrome may be having a RA factor also positive. Only if RA factor is positive, doesn't think about it is a rheumatoid arthritis, because in Sjogren's syndrome also RA factor may be positive. And in Sjogren's syndrome also, anti-DS-DNA. Anti-DS-DNA is very specific for systemic lupus erythematosus, but it can be seen positive in low titer in Sjogren's syndrome. And general other tests include erythrocyte sedimentation rate, C-reactive protein, both will be very much increased in Sjogren's syndrome. Then comprehensive metabolic panel to see the function of various organs. All the liver function does, renal function does, another metabolic panel has to be done, because it's a systemic disorder. It can affect the other multiple systems. And also complete blood count has to be checked to see how much how our immune system works, like RBC count, WBC count, platelet count. This will be affected with if there is a chronic disorder like Sjogren's syndrome. So it also has to be evaluated, and sequentially it has to be evaluated if you suspect or any autoimmune disease, especially SLE or Sjogren's syndrome. Always complete blood count has to be repeatedly seen to see or to evaluate the status of the blood count. Next is scleroderma. So scleroderma, it's a complex, very complex multi-system disease that often progressively affect the skin. It usually affects the skin. That means thickening of the skin is the hallmark of scleroderma. It affects not only skin, but it can affect the blood vessels, lungs, digestive tract, kidney, heart muscle, and bones. It can affect the lungs. There can be interstitial lung disease will be there. Endocarditis will be there. I had seen 1 to 2 patients dying in front of me with the scleroderma due to the chest tightening, and the patient could not breathe. So scleroderma, even though it affects skin, it's not only, it's a very dreadful disease where it initially starts with the skin, but it affects the other body organs like blood vessels, lung, digestive tract, kidney, heart muscles, etc. So usually a patient initially with the scleroderma, they will be having a thick skin at the palm. Usually at the site of the palm, the skin will be very thick, or the elasticity of the skin will be lost. If you pinch the skin, normally if you pinch the skin, you can get feel the elasticity. But patients with the scleroderma will not be having that elasticity of the skin. And also, patient with the scleroderma will be having a Raynaud's phenomena will be positive. That means if the hand is kept exposed to cold, there will be bluish color will be there. Joint pain will be there. Joint contracture or rigidity of the joint is another hallmark of scleroderma. Then swelling of hands and feet. Always the patient with the scleroderma will have a thick skin along with the swelling of hand and foot will be there. Then gastroesophageal reflux. Almost all the patients with the scleroderma will be having a gastroesophageal reflux. This is the difficulty in swallowing. Patient will usually find difficulty in swallowing in the later stages of scleroderma. Then fatigueness, muscle weakness will be there, dry mouth and mucous membrane, loss of appetite, and unexplained weight loss. Patient with the scleroderma, not only scleroderma, even SLE also may be having a weight loss, but in scleroderma, then unexplained weight loss will be there. Then constipation, diarrhea, malnutrition. These are the other clinical symptoms which are seen with the scleroderma. So in scleroderma, usually ANA test will be positive. Then scleroderma 70 antibody. That is very much specific for scleroderma. If it is positive, definitely it is a case of scleroderma. But scleroderma can be present without scleroderma 70 antibody negative also. But if it is positive, it is very specific for a scleroderma. Then centromere antibody is present in 50 to 96 patients with a limited cutaneous scleroderma. If there is a only cutaneous presentation, then it can be rarely positive. But if there is a crust syndrome is there, then anti-centromere antibody is very much positive. Then other general blood tests like CBC, then comprehensive metabolic panel, urine analysis, thyroid function. Okay, many times if the skin is very dry and elasticity is lost, we may think about the scleroderma. Sometimes it could be a thyroid disorder also. So always first rule out a thyroid disease in dry as well as in hard skin. Then only think about the scleroderma. First diagnosis has to be always about the thyroid. That was always think in the clinic. Many times if a patient says that my skin is very hard, always we think about the scleroderma. No, first you have to rule out a thyroid disease, then only think about the possibility of a scleroderma. Scleroderma comes second. In the clinical practice, what usually the patient presents with the thick skin in the palm with slight white hyperpigmented patches on the palm is the usual presentation in scleroderma. This is polymyositis. So in polymyositis, as you know, anti-Jo1, antihistidyl transfer RNA synthesis antibody will be positive seen in 30% of patients with the polymyositis. In polymyositis, what will happen? You'll be having a raised ESR. In polymyositis, usually the ESR will be above 80 or 100. Next is about the ankylosing spondylitis. Suppose if a patient is in 20s or 30s, complains of pain in the lower back, especially in the sacroiliac joint. If it is associated with the severe early morning stiffness and then oligoarthritis, if there's a 2 or 3 joints are affected with the severe early morning stiffness, we may suspect about an ankylosing spondylitis. If we suspect an ankylosing spondylitis, what we will do? We will take an X-ray of the sacroiliac joint to rule out an sacroiliitis. If there is a sacroiliitis is present, along with these clinical symptoms, because in the earlier stage, this bamboo spine and syndesmoid deposition will not be seen. Only sacroiliitis with the clinical symptoms will be there. In such condition, if you want to diagnose, second what you have to depend is that we go for the ESR and C-reactive protein. But one problem with the ESR and C-reactive protein in ankylosing spondylitis is that what will happen? This disease activity is not correlated. The ESR as well as C-reactive protein will not correlate with the disease activity in ankylosing spondylitis. Sometimes the disease will be very active, but ESR and C-reactive protein may be normal. That is one problem with the ankylosing spondylitis. So normally, what you have to do, if you clinically suspect an ankylosing spondylitis, then we'll go for a radiological investigation, either an X-ray of the sacroiliac joint or an MRI of the sacroiliac joint to confirm sacroiliitis. If there's a sacroiliitis with the oligoarthritis and early morning stiffness in a patient with the 20s or 30s, we doubt an ankylosing spondylitis. Next blood test is HLA-B27, human leukocytic antigen B27. 95% of the patient with the ankylosing spondylitis will be having a HLA-B27 positive, and patient with the ankylosing spondylitis will be having always have a negative rheumatoid arthritis. Very rarely it may be positive, but usually patient with the ankylosing spondylitis will be having HLA-B27 positive with the other symptoms of ankylosing spondylitis like sacroiliitis. In advanced stage, there can be syndesmophyte deposition in the ligaments, etc. will be there. This is how we need to diagnose ankylosing spondylitis. If you diagnose an ankylosing spondylitis at a very early stage, advise the patient to lie down in the prone position and tell him to learn swimming. Swimming is the best exercise to reduce the fibrotic changes happening in the sternal area, so that what will happen, the anterior posterior movement of the chest wall will be possible. So advise the patient to lie down in the prone position so that kyphotic deformity can be reduced, and also the mobility of the chest wall can be maintained if the patient go for a stretching exercise and swimming exercise. So this is how the ankylosing spondylitis can be diagnosed. Now, since psoriatic arthropathy, in psoriatic arthropathy, usually patient will be having a psoriasis. But sometimes psoriatic arthropathy can develop before the onset of skin lesions. But if a patient with the psoriatic arthropathy with the joint disorder, then usually it can be diagnosed as a psoriatic arthropathy. And the RF factor also sometimes may be positive in psoriatic, but there's no specific blood test to reconfirm the diagnosis of psoriatic arthritis. But ESR, C-reactive protein with the presence of psoriasis will reconfirm the diagnosis of a psoriatic arthropathy. Next is reactive arthritis. Nowadays, the reactive arthritis is very high because a lot of viral infections, from chikungunya to many nowadays, and the different strains of COVID, etc. are there. So usually after a viral infection, there is a more chance of developing a reactive arthritis. Sometimes following a post-diarrhea, following a viral fever, etc., patient may develop severe pain in the multiple joints. If there is a history of fever, followed by after a few weeks, followed by pain in the multiple joints, then the diagnosis of reactive arthritis can be considered. In reactive arthritis, ESR and C-reactive protein are very non-specific. As I said, like in ankylosing spondylitis, the C-reactive protein as well as erythrocytic sedimentation rates are very non-specific in reactive arthritis. So usually, history is the most reliable thing. If the patient is having a strong history of a viral fever or viral infection, after that, if the patient develops a multiple joint pain with the even in rise of temperature, fever, etc., then we have to doubt about an reactive arthritis. And HLA-B27 may be positive in 75% of the patients with the reactive arthritis. But reactive arthritis, again, the diagnosis is more clinical diagnosis. With the history is the more specific key for the diagnosis of a reactive arthritis. Next is the rheumatic fever. So this is one of two tests, that means ASO titer and anti-DNase B. These are the two tests which are abused, I could say, because every patient comes with a multiple joint pain. Doctors write RF factor, ASO test, and ANA. Usually, ASO titer means anti-streptomycin O will be positive if the patient is having a streptococcus infection. Suppose if a patient is having a streptococcus throat infection, or if the patient is having a streptococcus renal infection. After that infection, what will happen? ASO titer will be positive. That doesn't mean that patient is a case of rheumatic fever. If the patient is having a rheumatic, usually rheumatic fever occurs below the age of 15. In adults, the chance of rheumatic fever is very less. If the patient is having a very specific symptom of rheumatic fever, then only go for the testing ASO titer or anti-DSP. In simple multiple joint pain, it's very unlikely that the patient is having a rheumatic fever. Only in children, if they are having a fever or throat infection, following that, if the patient develops fever with the multiple joint pain and the rashes in the skin with the Huntington's chorea, etc., then only we should suspect about the possibility of a rheumatic fever, or if a patient develops a carditis or any other cardiac related issues following a fever, then only suspect about a rheumatic fever. Usually, if you check any patient, usually they may be having a ASO titer at the range of 200 or 300, because streptococcus infection is very common. So after even though if the streptococcus infection is over, for some time, for a few months, the ASO titer will be positive. That doesn't mean that patient is having a case of rheumatic fever. Usually, it has to be advocated in children only. That too, if strong clinical findings with the early history of a streptococcus infection is that then only go for the ASO titer as well as anti-DNase B. So I tell you, normally, if a patient is having a streptococcus infection, after 3 weeks to 1 month, what will happen? The ASO titer tends to increase, and after a few weeks, it peaks. It reaches a peak stage, then it gradually comes down. So normally, sometimes what will happen? A patient comes with the multiple joint pain. They may be having a rheumatoid arthritis. But when you check the ASO titer may be 300 or 400, because the patient may be having a recent strep infection. After giving the medicine for 1 month, we will check the ASO titer again. The ASO titer comes down. Normally, if you give medicine or does not give medicine also, after some time, the ASO titer will come down. The medicine does not have any influence over the ASO titer, because it indicates the recent strep infection, and after time passes, the value of the ASO titer comes down. It is not because of your medicine. So never claim that as I given the medicine, your ASO titer has come down. It's not like that. So it's an abused test. It should not be done so. Then ASO titer will be positive for only a few months only. But anti-DNase B, that's another test. That also detects the presence of a recent streptococcal infection. So after 3 months or 5 months also, and this anti-DNase B will be positively seen in the blood. So we can, if a patient presents with the clinical symptoms of rheumatic fever, and if anti-DNase B is positive, then diagnosis of rheumatic fever can be made, because from the anti-DNase B, we can come to know that the patient has got a recent history of streptococcus infection. So all streptococcus infection will not become rheumatic fever. Only few streptococcus infection in the childhood turn out to have a rheumatic fever only if there is a multiple joint pain, skin rashes, syndesmoid chorea with the carditis. Then only the diagnosis of rheumatic fever should be made. Only because of a joint pain with the ASO titer high, don't diagnose it as a case of rheumatic fever. So normally, after the infection, within a few months, within few weeks, the ASO titer will be raised, and if it reaches a peak, then gradually it comes down. It does not have any influence about the activity of the rheumatic fever or the medicines what you give, but it's a natural process. Anti-DNase B is more specific because anti-DNase B will be detected for little more longer time than ASO titer. Within few months, the ASO titer will come down, get settled, and you will not be able to know whether the patient are there resistant streptococcus infection or not. But anti-DNase B will be positive for a specific period of time or a long period of time, so that the diagnosis of the recent streptococcus infection can be more properly diagnosed with the help of the anti-DNase B. And the normal value of ASO titer is it should be less than 200 in adults, and in children it should be less than 100. And anti-DNase B, the values, it should be less than 85 units per milliliter in adults, and in children it should be less than 170 units per milliliter. So in second investigation, in rather than hematological investigation, the synovial fluid testing is also very important testing for diagnosing multiple inflammatory arthritis. For example, if you want to diagnose a gouty arthritis, the standard test or a gold standard test for diagnosing gouty arthritis is the synovial fluid aspiration cytology. In that, just if you keep in the microscope, you can see needle-shaped crystals of urate crystals can be seen, where the diagnosis of gouty arthritis can be made. If there is a pseudo gout, rhombo-shaped structure or calcium pyrophosphate deposition disease, you can get a rhombo-shaped crystals could be seen. And in other inflammatory monoarthritis, what will happen? There will be white blood count will be more. So synovial testing can detect many inflammatory arthritis. Even tuberculosis can be diagnosed with the help of the synovial testing. When RF factor can be, the rheumatoid arthritis, where there will be more neutrophil count will be there. If there is a gouty arthritis, urate crystals will be there. Likewise, synovial testing is also an integral part of diagnosing inflammatory arthritis. So, to conclude with the biochemical investigations of the inflammatory arthritis, no screening test exists for rheumatic disease. That first, there's no specific test because it's a battery of tests, has to be so proper history and a thorough physical examination. With the help of these hematological investigations, will help to diagnose this rheumatic disease. There is no single test exists for particular disease, but history, physical examination, and with the help of this multiple hematological tests, we can diagnose a inflammatory rheumatic disease. Occasionally, rheumatological laboratory investigation may be useful in confirming or ruling out rheumatic disease after clinical diagnosis considered. So, for example, if you suspect if a patient with multiple joint pain, if you doubt whether it is an ankylosing spondylitis or a rheumatoid arthritis, if HLA-B27 is positive and if RF factor is negative, then the diagnosis of ankylosing spondylitis is confirmed. So likewise, many a times multiple tests with the help of the physical examination help to diagnose. Also, once a rheumatic disease has been diagnosed, certain laboratory tests can help in assessing prognosis or determining the extent of disease. The earlier I said RF factor test. At the time of diagnosis, if the RF factor titer is very high, then it indicates that the patient is going to have a very worse prognosis of rheumatoid arthritis. With the rheumatoid arthritis, which will be having a very erosive arthritis is going to happen. So, rather than diagnosis and prognosis also, these tests are very helpful. Then laboratory tests may help the physician to monitor certain rheumatic disease, guide treatment, or assist potential drug toxicity. Suppose if the patient is having a rheumatoid arthritis, if the ESR is going very high, C-reactive protein is very high, patient is going to have a very erosive arthritis. Sometimes a cytotoxic drug may be required. Sometimes a modern cytotoxic drug or our Chandamarada Sindhura, likewise, certain cytotoxic drug may be required to control the disease. So, to assess it helps the physician to monitor certain rheumatic disease. Also, in systemic lupus erythematosus, if the HP is going very low, it indicates that there is a bone marrow suppression has been already happened with the help of the medicine. So the medicine has to be stopped, and we need to start certain drugs where the bone marrow can be activated. So to plan the treatment also, this laboratory tests are very helpful. So once the patient has gotten established rheumatic disease, to diagnosis, to assess that, to understand about the progress of the disease, to understand about the drug toxicity, for all these things, these hematological tests are very, very important. So judicious use of this rheumatological tests are very important for a proper diagnosis, proper management, and to reduce the complications of inflammatory arthritis. So thank you one and all for the patient hearing. Then Saturday evening, it says 2 days back only it has been informed. Then after the patients from morning to evening, and a class is definitely a tiring thing. I'm not in a very good mood to took the class. I hope you got something from my class, and thank you one and all for the patient listening. If you have got any doubts or something, you can ask, or you can WhatsApp to my number. Thank you one and all.
Thank you, sir. Dear participants, if you have any doubts,
Hello, sir.
Hello, yeah.
Sir, can I ask one question?
Yeah, you may go ahead. Go ahead.
Sir, you have said that in gouty arthritis, even if the uric acid is negative, also it may be, we cannot rule out gouty arthritis.
Yes.
This uric acid may be present in the joints.
Yes.
How can, in that condition, how can we diagnose, sir, whether it is gouty arthritis, since it is negative by other tests or by clinical presentations, it may be similar to RA. No? Therefore, how we can differentiate RA and uric acid? Sir?
See, in RA, there has to be symmetrical arthritis will be there. In gouty arthritis, is not symmetrical, but sudden onset of pain and swelling at a particular joint, especially if it is in the root of the toe, etc., then we usually doubt about the possibility of a gouty arthritis. When in the acute phase, what will happen? Whole of the uric acid crystals will be deposited at the site of the infection. If you are skeptical about the diagnosis, you can go for a synovial fluid aspiration. If you go for the study of synovial fluid study, then the diagnosis can be very well made. But clinical diagnosis. So the clinical diagnosis is more important rather than a laboratory investigation gouty arthritis. If it is in the root of the toe, or at the particular say sudden onset of pain, swelling, and very severe tenderness, severe explosive onset of tenderness, then the diagnosis would be usually gouty arthritis. Now, after a few weeks, once the swelling pain settles, if you check the uric acid levels, usually it will be higher at that time, or it will be higher than the level what you have checked on the day of the inflammation. But synovial fluid aspiration will cleanse the diagnosis. If you are very particular about the diagnosis, synovial fluid aspiration will give us the clue about the proper diagnosis. Then, if it is an RA factor, the symmetrical arthritis and other 7 points which has been said in the said by the American Rheumatological Association has to be met. Symmetrical arthritis in the smaller joints has to be affected like this.
Okay, sir. Thank you, sir. What all treatment differences we have to make in between RA and gouty arthritis, sir? In Vardha treatment has to be done in both, or any differences?
It depends. In Ayurvedic treatment is concerned, for us it is not actually, we don't consider it as RA, but it's about the clinical presentation. Regarding it's based on the clinical presentation. We need to plan the treatment. It is not about a rheumatoid arthritis treatment, gouty arthritis. No, it has to be based on the clinical presentation and the Ayurvedic diagnosis at that time. Usually in gouty reaction, we make the clinical symptoms may be based on the Vata Rekta, but if it is a rheumatoid arthritis, usually the features of Amavata could be more prominent. So based on the clinical presentation, at that time, we need to plan the treatment.
Okay, sir. Thank you.
Dr. Archana, you have any doubts? Doctor, please unmute and ask, doctor.
Hello, sir.
Hello. Yeah.
Sir, one more question is there, sir. Sir, as you said, you have said that that Amavada or ASO titer, rheumatic fever is commonly occurring in children below 15 years of age.
Yes.
Normally, I have seen, sir, in my hospital also, many of the doctors write the ASO titer in most of the patients who are elder 50 years ago. Also, they write ASO titer as a test. Normally, according to you, that it is not needed for elder persons, sir.
Usually, it is not needed for elder patients. But if clinical symptoms warrants, suppose if at the childhood time, if the patient has got a rheumatic fever, or in the adults, actually, very rarely rheumatic fever happens. If it happens also, it can happen. It doesn't rule out that actually it may not happen, but very, very rarely it can happen. But clinical presentation of ASO is very particular. There can be a skin rash should be there, carditis should be there, then chorea should be there. If these clinical symptoms meets, very strongly meets, then only go for the ASO titer. Otherwise, there is no need to go for the ASO titer. For every pain and swelling of the joints, ANA, RA, and ASO, it's not required. ANA is absolutely not required in such condition, because ASM, because what will happen, it will wrongly guide the physician, because if the ASO may be positive, because he may be having, because usually streptococcus infection is very common, streptococcus throat infection is very common. So what will happen, the ASO titer will be high and we will diagnose it as a case of rheumatic fever. No, the ASO indicates only there is a recent strep infection. It does not diagnose a rheumatic fever. Rheumatic fever, it has to be diagnosed, it has to fulfill the criteria of carditis, arthritis, skin involvement, neurological involvement, etc. Then only the diagnosis of rheumatic fever can be confirmed. Only based on ASO, if ASO is positive, it says only a recent streptococcus infection, not rheumatic fever. That has to be always understood.
Okay, sir. Sir, commonly in hospitals, in colleges, we see that it's commonly correlated as this rheumatic fever as Amavada and rheumatoid arthritis as Vata Rekta. Is it correct or not, sir? According your opinion, according
any treatment, it does not don't depend upon the modern diagnosis. What is the particular presentation at that time, and what is the particular dosha seen at that time? What is the clinical symptoms, Ayurvedic symptoms seen at then treatment has to be made accordingly. But as a general rule, actually, or what you have seen in more number of patients, if it is a rheumatoid arthritis, it could be usually the symptoms of Amavada will be seen. If it is a gouty arthritis, the symptoms of Vata Rekta will be seen. That is what the general scene. Also, in gouty arthritis, also symptoms of Vata Rekta will be more seen. That is a general rule, but that rule should not be applied. Always match the patient according to the doshic and symptoms, according to that particular presentation, and plan the treatment accordingly. There is no rule like that. This will be this. This will be this. If you start treating in that manner, you will definitely land up in very bad results out from the treatment. Ayurveda treatment has to be based on the doshic presentation seen at the particular time of clinical presentation.
Okay, sir. Thank you very much.
Sir, one question by Dr. Archana.
Hmm.
Amavada effective Ayurvedic drug or combination? Which dosha is pradhana in that vada along with? Does yoga therapy benefit in this?
First, let me start from the last question, that is whether yoga benefits out from that. Definitely in all rheumatological, as you know, our mind is more important in autoimmune diseases. So if you are having a very strong willpower, definitely autoimmune disease can be handled to certain extent. So definitely yoga is helpful. Second, in any inflammatory arthritis, mobilization of the joint is a part of the treatment. So yoga can mobilize the joint without putting much strain to the joints. Unlike other physiotherapy exercise, there will be more strain into the inflammatory joint, but yoga can have a mobilization to the joint without putting too much of strain to the joint. So definitely yoga, both as an autoimmune disease to strengthen our immune, our mind power, which can overcome such autoimmune diseases. At the same time, to mobilize the joint without putting too much of strain or putting too much of further damage to the cartilage, but still the mobility can be maintained. So yoga is definitely an excellent modality of treatment in case of any inflammatory arthritis, whether it is a systemic lupus erythematosus, if it is a rheumatoid arthritis, whether it is a gouty arthritis, etc. In all these modalities, yoga is found to be a very beneficial and essential or integral part of the treatment. That's what I feel. Second, and depending upon what you asked about then particular drug. If I say a particular drug, it could be Amrita. In any of the inflammatory arthritis, our Guduji is found to be an of the best drug of choice, which will be because it has got some effect on our immunoglobulins, whereby we can benefit out from the treatment. So any combination with Amrita, with this Amrutotana Kashayam, Amrita Arishtam, etc., is found to be the best combination drug for this inflammatory arthritis. Even if it is a gouty arthritis, Amrita is found to be a very beneficial drug. In almost all the inflammatory arthritis, I always choose some Amrita preparations because that gives an excellent result.
Thank you, sir. Dear participants, if you have any questions. Sir, how to approach in acute condition of inflammation of joints?
So any acute inflammatory conditions, because for example, if you're having a gout, because it has to be approached in different manner. Suppose if you're having a gout, if you're having an acute gout, very severe, if the pain is not responding in after 2 or 3 days, sometimes we may be required to start our Panchakarma treatments. In acute gouty arthritis, I may suggest about a Manjishtadi Sharabasti. But even severe pain, painful conditions, if it is a gouty arthritis, advise the patient to drink lot of water with the Coagulaksha. I usually suggest the patient to drink Coagulaksha because I advise them to boil water with the Coagulaksha in it and advise them to drink plenty of water, 4 to 5 liters of water in the first day. If it is an acute gouty arthritis, usually that gets settled with the help of the Coagulaksha Pana itself. If it is a rheumatoid arthritis or if it is an amavata, then our amahara treatment has to be advocated. Like sometimes I may go for the acne leba, sometimes I go for the dhanyamladara, along with our general internal medicines. So depends upon the condition. If there is a severe burning pain with inflammatory arthritis, I may go for the Gudujadi Shira Dara at that particular site. So it depends upon the clinical presentation of the patient.
Okay, sir. Lipid profile, any influence in joint disorders?
No, I don't have much idea about that.
Sir, any common plan for Amvata Rogi?
Any common?
Eh,
Pana, okay.
okay.
Usually in Amo, the patients for Kokshura and Shundi Churna, that's with the boil it and that has to be given for drinking. That's the best pana which is good for Amavada Rogis. Gokshura and Shundi both has to be powdered, boiled, filtered, and that water has to be taken. That's found to be very beneficial in patients with the Amavada. Chigilsa Manjari, there is a reference about that.
Thank you, sir.
Okay.
Hey, participants, if you have any doubts,
If no doubts, can we wind up? Because rounds are
okay,
still
sir.
pending.
Okay, sir. I think questions are seems to be over. Sir, Bahi Chikilsa and Amvada.
As I said, actually, Dhanyamladara can be given. Then this Acne Chikilsa can be planned. These are the best modalities which can be given in Amavada. Then Kotanjukadi Churna with Dhanyamla can be mixed and put at that particular site. So any Demanapajana type of drugs can be mixed and applied to that particular site. But Dhanyamla in Kerala, Dhanyamla is a miraculous preparation that is can be given in any such kapha samsrishta conditions. Now, Amavada Dhanyamla is a very miraculous preparation. Usually start the patient, Amavada patient with the Dhanyamla Dara for 3, 5, or 7 days.
Thank you, sir. Okay, sir. Thus we come up to the end of the session. Before winding up, let me thank our eminent chief guest, Dr. Shibu Varghese, for accepting our invitation without refusal. I take this opportunity to extend my sincere gratitude to you behalf of GDH Varkala. Next, I would like to extend my sincere gratitude to each and every person for attending this seminar. Thank you for being with us till the end. Thank you, sir. Thank you so much.
Thank you.
Thank you, sir.